Hello, my name is Johanna Bendel, and I am Chief Development Officer and Director of the Drug Development Unit in Nashville at the Sarah Cannon Research Institute at Tennessee Oncology. On behalf of the study investigators, I would like to thank the Kidney Cancer Association for allowing me to present results from the CheckMate 920 trial of first-line nivolumab plus ipilimumab for patients with advanced renal cell carcinoma. Here are my disclosures. Nivo plus Ipi demonstrated long-term efficacy and tolerability for first-line advanced renal cell carcinoma in the registrational CheckMate 214 trial and is the basis of the current approved dosing. The community-based multi-cohort phase 3b/4 CheckMate 920 trial was conducted to evaluate modified Nivo plus Ipi dosing in predominantly clear cell advanced renal cell carcinoma, as well as standard dosing in patients with clinical features mostly excluded from phase 3 trials. Here we present the results of the CheckMate 920 modified Nivo Ipi dosing cohort. In this non-randomized open-label clinical trial of first-line Nivo plus Ipi treatment, patients with previously untreated advanced or metastatic renal cell carcinoma with no prior systemic therapy and any IMDC risk were assigned to one of 4 cohorts. Patients with predominantly clear cell renal cell carcinoma and a Karnofsky performance status of at least 70% were assigned to cohort 1. Treatment for cohort 1 was Nivo 6 milligrams per kilogram plus Ipi 1 milligram per kilogram every 8 weeks, alternating with Nivo 480 milligrams every 8 weeks. This alternating dosing was staggered every 4 weeks for up to 2 years or until disease progression, unacceptable toxicity, or withdrawal of consent. The primary endpoint was all-cause grade 3 or higher immune-mediated AEs. These were specific events that occurred within 100 days of the last dose of study drug. Secondary endpoints included progression-free survival and overall response rate, both based on RECIST version 1.1 per investigator assessment, and time to and duration of response. Treatment-related AEs and overall survival were exploratory endpoints. The minimum follow-up for cohort 1 was 28.5 months. Overall, the patient population was typical of first-line advanced clear cell renal cell carcinoma. The distribution of patients by IMDC risk group is similar to other clinical trials of advanced renal cell carcinoma. 11.3% of patients had sarcomatoid features, and 98.1% of patients had stage 4 disease at study entry. A total of 106 patients received study treatment. With a minimum follow-up of 28.5 months, all patients had discontinued treatment, 58.5% due to disease progression and 18.9% due to study drug toxicity. Patients were treated for a median of 5.1 months with Nivo and 4.0 months with Ipi. The majority of patients received a relative dose intensity of 90% or higher. Patients received a median of 6 doses of Nivo and 3 doses of Ipi. Unlike the approved dosing for first-line renal cell carcinoma, Ipi was not limited to 4 doses. 40.6% of patients received 5 or more doses of Ipi. This table shows the incidence of immune-mediated AEs by category. These were specific events that occurred within 100 days of the last dose of study drug, were of any causality, had no clear alternate etiology based on investigator assessment, or with an immune-mediated component, and treated with immune-modulating medication, with the exception of endocrine events. The incidence of high-grade immune-mediated AEs is shown, which was the primary endpoint of the study. The most common grade 3 or higher immune-mediated AE was diarrhea or colitis in 7.5% of patients. No grade 5 immune-mediated events were reported. The most common any grade immune-related AE was rash in 23.6% of patients. Overall, 36.8% of patients received corticosteroid treatment of at least 40 milligrams of prednisone or equivalent to manage the immune-mediated AEs. 24.5% of patients were treated for at least 14 days, and 7.5% of patients were treated for at least 30 days. In the exploratory endpoint of treatment-related AEs, 88.7% of all treated patients had any grade treatment-related AEs, most commonly fatigue in 46.2% and diarrhea in 29.2%. 43.4% of all treated patients had grade 3-4 treatment-related AEs, the most common of which were lipase increased in 14.2% and amylase increased in 4.7%. No grade 5 treatment-related AEs were reported. 28.3% of all treated patients had any grade AEs leading to discontinuation, the most common of which were colitis, malignant neoplasm progression, pneumonitis, and diarrhea, all occurring in 3.8% of patients. 19.8% of patients had grade 3-4 AEs leading to discontinuation, the most common of which were colitis and malignant neoplasm progression, both in 3.8% of patients. The secondary endpoint of investigator-assessed overall response per RECIST version 1.1 was 34.4% in response evaluable patients. 5.2% of patients achieved a complete response and 29.2% received a partial response. 29.2% had stable disease and 32.3% had progressive disease. Median time to response was 2.9 months and median duration of response was 9.2 months. In the secondary endpoint of progression-free survival per investigator, median progression-free survival was 4.8 months in all treated patients. The probabilities of progression-free survival at 12 and 24 months were 28.7% and 15.9% respectively. In the exploratory endpoint of overall survival, median overall survival was not yet reached. The probabilities of survival at 12 and 24 months were 78.1% and 62.2% respectively. With similar follow-up, efficacy measures with modified Nivo plus Ipi dosing in CheckMate 920 showed no evidence of improvement relative to those seen with standard combination dosing in CheckMate 214. However, with the former being a non-randomized community-based trial and the latter being a randomized trial conducted in academic settings, direct comparisons cannot be made. In summary, no new safety signals were reported with the modified Nivo plus Ipi dosing for first-line advanced renal cell cancer. Anti-tumor responses showed no evidence of improvement relative to those with standard combination dosing in CheckMate 214 after similar follow-up. However, CheckMate 920 and CheckMate 214 differ in their design and setting, and direct comparisons cannot be made. The anti-tumor activity observed in CheckMate 920 therefore reinforces the use of the standard combination dosing employed in the pivotal CheckMate 214 trial and currently recommended for advanced renal cell carcinoma. Here are our acknowledgements, and thank you so much for your interest in this study.